Hi, this is Elliot Fishman, and welcome back to part 3 of our look at the anterior mediastinum and anterior mediastinal masses. I left off last time making the point about invasive thymomas, that we talked about thymomas and myasthenia gravis, and the fact that thymomas are usually solid, some enhancement. They can be benign, they're often well-defined and smooth, but in a case like this, you're losing the plane to the anterior chest wall, you're losing the plane to the aorta, and you see the pleural effusion with lobular masses on the pleura. And that's a classic appearance for malignant or invasive thymoma. Probably all thymomas we would call malignant, but the correct term is invasive thymoma. Nice implants on the pericardium, nice implants on the pleura, and infiltration into the mediastinum. Here you can see it nicely on the pericardium. Again, other things you might think about lymphoma, but everything is unilateral. And with thymoma, particularly early on, both the presentation as well as the implants, it's more common to be unilateral, often eccentric. I mentioned that in the last talk. And here's a nice eccentric mass growing down along the pericardium with implants on the pericardium, implants on the diaphragm, and implants on the pleura. Now, I mentioned that one of the challenges is cystic lesions. We talked about thymomas. We talked about cystic thymomas. Remember, we said that thymic cysts are benign lesions, but there can be an overlap. I showed you in part 2 a few cases of thymic cysts, but here's a cystic thymoma. I have to admit, you could think about a thymic cyst, but there's some areas of subtle increased density, a little bit thickening of the wall. It is eccentric, but it is very cystic. And this is one of those difficult cases where, how do you know it's not a cystic, just a simple cyst rather than a cystic thymoma? I think at the end of the day, the patient will get surgery and this will be resected. In this case, I would have been more suspicious for a cystic thymoma because of the thickened wall, the irregularity. It doesn't have that smooth shape. You can see it nicely here that we saw before looking at thymic cysts. But again, it's one of those more difficult differential diagnoses. And again, it's less common. When the CT features of a cystic prevascular mass are equivocal and a complex cyst is suspected, MRI may be helpful. But again, at the end of the day, I think you're going to end up with biopsy, which often is not perfect, so people will simply go in and resect it and make a definitive diagnosis. And again, we talk about different things in terms of thymic imaging, some of the pitfalls. One of the pitfalls also you need to look at very carefully is with thymic malignancies like thymoma, to look very carefully at the pleura. Sometimes we see lesions in the thymus that don't seem to be that aggressive, but the patient has early pleural implants. So you want to look very carefully for potential pleural implants, diaphragmatic implants, and pericardial implants as well. Now, what about this case in this patient with chest pain? Anterior mediastinal mass eccentric with calcification. So my first thought would be, again, thymic mass, thymoma. I could think about lymphoma, but I couldn't explain the calcifications. It's not thyroid. It could be a teratoma in theory. You look at it a little bit more carefully, you see the coarse calcifications, you see the solid nature of the mass, and I would have gone probably with a thymoma. But I mentioned before that thymoma is not the only thymic malignancy. Thymic carcinoma is one of the things to think about as well. It's less common. Paraneoplastic syndromes are rare with thymic carcinoma. The distinction between thymic carcinoma and high-risk thymomas can be challenging, but thymic carcinoma tends to exhibit internal heterogeneity and higher rates of infiltration into the surrounding structures, along with an increased frequency of distant metastasis in this article by Kayashu. So what you're basically saying is thymic carcinoma is a more aggressive tumor, but sometimes you just can't tell the two apart. We also talk about neuroendocrine tumors arising from the thymus. They also are fairly aggressive lesions. They're often classified into carcinoids and or atypical carcinoids and typical carcinoids, but that's something on imaging we're just not going to be that great with. And again, looking at the prior case, the eccentric nature of the mass, again, calcification, thymoma would be right up there. So surely you would have been right saying it's a thymic tumor. I worry about malignancy, but this was a thymic carcinoma. Just a very, very nice example. And again, the calcifications may be a bit more common in thymic carcinomas, but they're not that common in those lesions either. And here it is on the 3D mapping with volume rendering as well. Now you can see, interestingly, this patient also had a non-contrast scan at some point, and in fact this one was when it was picked up. But you could see that soft tissue density, about the same density or a little bit more than the aorta. But again, you got to be thinking malignancy when you see this case. So an epithelial neoplasm, one of the thymic tumors. Another case, large anterior mediastinal mass. This could be an aggressive thymoma. Also, lymphoma, big bulky anterior mediastinal mass. There's paratracheal nodes. There's some right hilar disease. So we talk about differentiating lymphoma sometimes from thymic disease, particularly thymic cancer, can be very difficult. Again, you see it's growing down. It's involving the pericardium. This is the greatest case. When I looked at it, I thought that it was probably going to be lymphoma. And to my surprise, when it ended up being a thymic carcinoma, again, the appearances are so classic for lymphoma. But again, thymic tumors, this is not going to be the look of a thymoma, but a thymic carcinoma, which looks identical to lymphoma. Really nice example. Yes, you might say lymphoma is more likely to have abdominal disease, but a lot of lymphoma cases, particularly B cells, simply have disease in the mediastinum and no disease in the abdomen. Here it is in the sagittal view with some vascular compression. Another example, another thymic carcinoma. Again, aggressive looking, infiltrating. I would have read this as a thymic mass. Could be lymphoma, but I would have gone with thymus and I would have said thymoma. Pathology proved it to be a thymic carcinoma, making the point that you will get biopsies. You also will try to get surgery. With thymic carcinoma, they'll try to resect it. If not, they'll get a combination of chemotherapy and radiation therapy. It's hard to get clear planes, and these tumors are going to be aggressive. So again, we talked about benign thymic lesions, and then we talked about malignant thymic lesions, and we always talk about thymomas, but to make the point, you got to think about thymic carcinomas and thymic carcinoid tumors. Now, going back to the 3 T's, thyroid, thymus, and the other one is teratoma. These are typically benign mediastinal tumors. Classically, they contain fat and fluid and calcification, and they have a really pathognomonic appearance, right? Particularly when you see fat in the lesion. They're more commonly in younger patients, but sometimes you do pick them up in older patients. Classic appearance. The soft tissue component, you could say, well, lymphoma, thymoma, a number of things, but the low density cystic areas measuring fat with the coarse calcifications seen right here, that's going to be a teratoma. And it's just a classic case. You see it very nicely here. And here's a little bit lower. You can see it's eccentric. It can be very large. Most thymomas are large. You could see a 2 or 3 centimeter teratoma, but it's rare to see that. Most teratomas are going to be large masses. Thymomas can be smaller. So if I think about things in the anterior mediastinum and differential diagnosis, when I see fat, I'm going teratoma. When I see calcification with fat, it's teratoma. Calcification without fat is kind of tricky because it could be teratoma, but unusual. And I showed you the case of thymic carcinoma and occasionally thymoma. So the calcification makes it more difficult. It kind of expands rather than narrows the differential diagnosis. Here's that teratoma with a nice coronal and a nice volume rendered view. Teratomas, like thymomas, are often eccentric. Here it is nicely on the sagittal view. Here's another example, large cystic mass, eccentric. You can see what looks like nodules here, almost layering out with almost a fluid level. This is also a teratoma. I show this case to make the point that not every teratoma is going to have fat, but cystic may have soft tissue components layering out. You would look at the abdomen and pelvis, make sure you're not dealing with something else going on. Could this be lymphoma? I guess, but it's so cystic. Could it be an infected thymic cyst or a cyst that previously bled? I have to say that would be a possibility. If you have a thymic cyst and it bled, which is not that rare, you can see soft tissue simply layering out. But for a thymoma, I don't like it. Cystic thymomas we talk about, so I guess it's in that differential. This was resected. This was a teratoma. So again, I showed you a super classic teratoma, fat and calcification, and I showed you one that's not so classic. That's cystic, no fat, no calcification, and soft tissue layering out in this patient. And you can see it very nicely how far down it extends on the patient's coronal or 3D reconstructions. Just a really, really nice example. So again, the spectrum of teratoma. And here's another patient, anterior mediastinal mass. You can see it's pushing on the vascular structures. This was a teratoma. It was a germ cell tumor metastatic to the mediastinum, but it was a teratoma at path. 90% of the lesion was a teratoma, eccentric with calcification. So that's what you need to be thinking about. So we've done the 3 T's. Now comes the L. Primary mediastinal lymphomas occur. We talk about distribution of lymphoma in the anterior mediastinum, middle mediastinum, and posterior mediastinum, but most classically it's an anterior mediastinal mass. We talk about the different types, from nodular sclerosing, Hodgkin's disease, to T-cell lymphoblastic lymphoma, to B-cell lymphoma. We talk about the fact that the masses can be large, they can be small at times, they can be infiltrating, they can be cystic, but usually that's due to therapy. You can see extension into the hilar regions, and of course with lymphoma it may not remain only in the mediastinum, and so you may see disease in the abdomen, you may see in the liver, the spleen, the kidneys, or adenopathy. Pleural and pericardial effusions are seen in about half of these cases. Non-small cell Hodgkin's is common in younger females. So again, the age of lymphoma will vary. There's a few different spikes. There's different tumors in different age groups. The T cells are more common in younger patients and more common in male patients. So again, it's that appearance. I showed you that case before of that aggressive thymoma, and there is an overlap between lymphoma and thymoma. Obviously, if I see disease in the abdomen or liver and spleen, even alone, I'm more likely going to think I'm dealing with lymphoma. And again, anterior mediastinum is probably the best place for lymphoma, but it can involve lung and thymus and pleura and chest wall and middle mediastinum, superior mediastinum, posterior mediastinum. CT is currently the most important imaging modality for the evaluation of thoracic lymphoma, but PET-CT, as I'll show you, also plays an important role. And here's an example. You can see the patient has a small anterior mediastinal mass. They had some chest pain. The mass is not that large. It's really, what would you say, 2.5 centimeters? But it's there. The patient's in their 30s. You can see this breast implants. You can see the mass on the coronal view. What could it be? It could be a thymoma, right? Possibly. It could be adenopathy. The patient had a PET scan. This area was hot on the PET scan, very hot. The rest of the chest and the abdomen and pelvis and everywhere else, The PET was negative, so it's really this mass sitting on the aorta. We go through a differential. We talk about lymphoma as a possibility. We talk about thymoma. We talk about metastatic disease, but there's no sign of any other primary tumor. This was biopsied, a great example of B-cell lymphoma. So again, we talk about lymphoma as large masses, but they don't always need to be large masses, as was the case here. And we talk about Hodgkin's disease, the most common lymphoma with mediastinal lymphadenopathy, and most frequently involving nodes in the anterior mediastinum and paratracheal regions. And then again, with lymphoma, the nodes tend to extend down and not typically skip specific areas. We talk about the nodes being soft tissue attenuation. They may have some slight enhancement. Occasionally, they can have cystic changes. Of course, once you're treated with radiation or chemo, cystic changes in lymph nodes is more common. We also mentioned that lymphoma rarely calcifies. When lymphoma calcifies, it's usually after therapy, typically radiation therapy. But necrosis of nodes can occur, and it can occur in about 21% of Hodgkin's lymphoma. When they're cystic, they can look like infection. I've seen cases that have been confused with like TB or vice versa. Although there are many subtypes of non-Hodgkin's lymphoma, large B-cell lymphoma and lymphoblastic lymphoma are the most common subtypes, particularly involving the anterior mediastinum. And again, we talk about lower density zones. We talk about lymphoblastic lymphomas are highly aggressive and high-grade lymphomas arising from thymic lymphocytes. So again, there's a range of aggressiveness, and how you manage these patients will vary depending on what the biopsy shows. I mentioned calcification is usually due to radiation therapy or potentially chemotherapy. Dystrophic calcification may develop in lymph nodes following radiation, and it may take years for it to happen. Lymph node calcification before treatment is unusual, and again, maybe the patient had TB in the past and those nodes are involved by the malignancy, but typically when I see calcifications and the patient has not been treated for anything, I'm always thinking about something beyond lymphoma. Some examples: large mediastinal mass, B-cell lymphoma, paratracheal nodes, pleural effusion, implants. Again, could this be an aggressive thymoma? Absolutely. Look at the extent and the way it extends downward. It's solid, it's enhancing, pushing on the vascular structures like the aorta. It can compress the SVC and give you SVC syndrome. You can see it very nicely in its extent on the sagittal view and the coronal view. Here's an example of acute lymphoblastic lymphoma. Again, large mass, bulky, compressing the SVC and narrowing the SVC. And this tumor extends down. There's a pleural effusion, and there's also involvement of the patient's right kidney. So when you're staging patients or you're looking, what's that mediastinal mass? Remember, thymoma, we're not going to see anything in the abdomen typically. We're not going to see things with substernal extension of the thyroid, obviously. But when we see involvement of the kidneys, the liver, or the spleen, or bulky nodes, we got to be thinking that we're dealing with lymphoma. And again, nicely shown here, the involvement of the right kidney with infiltration. And we talk about lymphoma having many appearances of the kidney. One of them is going to be infiltration, as was the case here. If you didn't know about lymphoma, you could have thought about an infiltrating transitional cell carcinoma, perhaps, as a likely diagnosis. The extension through the chest wall or involving the chest wall, we mentioned thymoma, but lymphoma is one of those lesions. Look how extensive this tumor is, extending to the left of midline in this patient with Hodgkin's lymphoma, and really bulky disease. Secondary involvement of the pericardium, of the pleura, is seen in this example. And as you go to the coronal view, you really appreciate the full extent of disease and full extent of involvement. Just a really impressive example, and lymphoma does give big masses. And I showed you the first case with lymphoma. It was that small 2 or 3 centimeter mass. That was the only extent of disease. Here, involvement of the pericardium, involvement of the pleura, really large mediastinal mass. Again, lymphoma has a wide spectrum of appearances. Again, very nicely shown in this case. And again, with the MIP imaging showing you some of the abnormal vascularity within the lesion proper. And of course, when you get a PET scan, very, very avid. You can see the extent, the infiltration of the pericardium on the left side, infiltration of the pleura, and the very large aggressive mass. And in this patient, there's no disease, at least on these images, in the patient's abdomen. So let's do this. I want to make a few more comments about lymphoma, but let's pick it up and start that in the next lecture. So let's take a little bit of a break, and I'll see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.